Next speaker is 吴鹏煌 from 新加坡。下一个讲者是来自新加坡的吴教授啊，因为时间关系，我们最后再讨论。For the time limitation, we began next speaker. 吴教授，你可以开始。可以。吴教授，你的 PPT 是英文吧？
我会用英文解说。然后给我一点时间，现在我分享一
下。胡教授呢是新加坡最早进行双通道技术的一个专家啊，也非常有经验。
你们有看到我的那个 slides 吗？
看到了。
好，我用英文解说哈因为我们也有国际上的其他的那个专家。Good afternoon, everybody. I'm Dr. Pang Hong Wu. I'm from Singapore. I'm a consultant in National University Health System, Ng Teng Fong General Hospital. Today, my topic will be clinical applications and differences in uniportal and biportal endoscopic spine surgery and lumbar decompression. 今天我说的都是以单管道和双管道内视镜手术的一个减压手术的解说。Thank you for the invitation, and I'm very honored to be among the experts in discussing this forum. I practice in Jurong Health and a part of the National University Health System. We take care about 12% of Singapore's population. In 2020, I performed 60% of my cases as endoscopic spine surgery. And in 2021, this year, I did about 80% of my cases as endoscopic spine surgery. 70% of my surgery are uniportal and 30% of them are biportal surgery. And most of them are stenosis decompression. I have learned my trade of scope from Korea. I thank my mentor, and I also listened a lot to Dr. Song's lecture. I also personally would like to thank him for all his teaching. There's a lot of exchanges with Professor Xi and Professor Zhang Wei and other Chinese professors. Thank you all for your expert opinion. So in uniportal surgery, a lot of time we need to dock and work around the dock area with some exceptions. We need to be very precise in docking, both in the Campin's triangle or in the interlaminar space. For stenosis, we use a bigger scope, bigger working channel scope with a shorter length and 15 degree, while for the transforaminal scope, we use a longer length and a smaller inner diameter scope. Hence, there are various different instruments as well as different size drill is needed to fit in this small working channel. However, in biportal surgery, we can stand in comfortably in one position with a left non-dominant hand as a viewing portal, while dominant hand holding the working portal. We can do that in cervical, thoracic, lumbar, and for all various types of surgery, pretty much holding the scope and working instrument in the same position. The benefits of endoscopic surgery is enormous. In biportal surgery in particular, is a floating technique. It has a less infection rate. It gives a panoramic view and with a familiar anatomy. There is a less limitation of working space. Hence, in biportal surgery, we can use normal spine instrument. We can they are independent of each other, and hence we do not need to rotate or manipulate our non-dominant hand, the left hand, to facilitate looking at the tip of instrument. High magnification view and using normal instruments allow us to perform very advanced technique like the others talks that shows about fusion. And more importantly to the surgeon, we have some training in, especially in orthopedic and in arthroscopy and neurosurgery for endoscopy in the pituitary fossa. We can stand in good upright posture, and as we age, our eyesight may not get so good, but we can get a bigger TV, a higher definition TV, and hence can allow us to do this surgery till old age and retirement. We can engage an assistant in biportal surgery, while uniportal surgery cannot do that. And we are familiar with the instrument in biportal surgery as we do that in open surgery as well. However, there are some weak points to our biportal surgery. There is soft tissue bleeding, and we are very sensitive to soft tissue bleeding. You can provide us with a red screen and you cannot see well. So with experience, we can overcome that. AO Spine has recently have a consensus paper after various meeting and label uniportal surgery as full endoscopic surgery, while biportal surgery is endoscopic assisted surgery, and they give the name of UBE and various other uniportal names as well. In this COVID-19 period, I think early post-operative recovery and decreased length of hospital stay is not only a good to do, but something we should do. We need to free up hospital bed for patients who potentially may have coronavirus. And this is more of a public interest now to decrease the time of length of stay in hospital after spine surgery. It's not only for our personal gain or the patient's interest anymore. So what is the technical difference between uniportal decompression and UBE? I've published a couple of papers to highlight the difference between uniportal surgery, both are as early career challenges, as well as in terms of tips and tricks. So the main thing is in terms of skin incision, soft tissue, bone laminar, and facet resection has been highlighted in these papers. Just to highlight a few points, I think I brought on the concept earlier. We can engage more manpower in biportal surgery, and the start point is different. So this is the other paper that we published to highlight the differences between them. Just to summarize, in terms of handling and standing posture, as I alluded to, the non-dominant hand holds the scope, and we typically have two positions of holding the uniportal scope. One is a gun position where we use the index finger to manipulate the depth of the scope, or we can hold it in upward holding a thumbs up position where we use the little finger to manipulate the depth of scope. We need to rotate the scope quite frequently in uniportal surgery. While biportal surgery, if you use a 0-degree scope or 30-degree scope, then there's less need of manipulation of our non-dominant hand. Most of the work is done by the dominant hand holding the working instruments. So we can stand in one position throughout the surgery and perform biportal surgery. While in uniportal surgery, we need to rotate our body frequently to have a better visualization of the tip of the instrument. And I find that our shoulder abduction position, we tend to abduct our shoulder more in uniportal surgery because the working channel is higher. While in biportal surgery, the working portal is right on the skin of the patient, and hence we hardly need to abduct our shoulder in biportal surgery. It's good for our health if we have a shoulder problem as a surgeon. In terms of instruments, as I mentioned, uniportal surgery needs specialized instruments, so the startup cost is more expensive, and you need there are 3 to 4 different type of scope as a basic requirement. So you need probably 3 or 4 trays of instrument. While in biportal, you can just have a general tray and a biportal tray, so it's easier and cheaper to start the surgery. In terms of inflow and outflow, uniportal has the advantage of basically if you dock right at the correct point, the inflow and outflow is not limited by skin or fat that's above the scope. However, the disadvantage is that it is very sensitive to bleeding right in front of the lens. So once epidural bleeding is started, sometimes you have to increase the blood flow, the pressure flow of the fluid. I find that when I'm doing biportal surgery, I can maintain the inflow and outflow at a relatively decent 30 to 45 millimeter mercury throughout the entire surgery, while in uniportal surgery, we have to vary quite a bit when we drill as well as when we do the epidural dissection, when we stop the epidural bleeding. In terms of docking point in uniportal surgery, I've actually published a couple of papers highlighting where we dock. I typically did a sublaminar approach, as you can see on the left picture. The blue color is the sublaminar approach, while the red color is a translaminar approach. The sublaminar approach looks up in the base of spinous process and dissect the ligamentum flavum, drilling it off and as an entire piece. While biportal surgery, which I'm going to publish in our an atlas of surgical techniques next year, we have the dock as I tend to adopt what Professor Shi, Dr. Song, and many of the China professors docking point, which is the base of spinous process, spinolaminar junction, which is right here. So I find that I also use a green needle, and I mark the medial pedicle line, and I do about 1.5 cm up and down from the spinolaminar junction, and I find that that typically brings about 2.5 cm between the working portal and viewing portal. So I find this easier to perform. In terms of BES and UBE, I think there's subtle difference if you use a lot more osteotome and less drill, and you can move your viewing and working portal a bit more medially. While in UBE, we tend to be a bit more lateral in terms of the viewing and working portal. We can engage surgical assistant, as I mentioned, in UBE, but not when we do open surgery. And we try to limit the number of portals in, we try to limit the number of portals in uniportal surgery. To me, uniportal surgery, you really try to do one port and multiple levels. And if we have to do 3 or 4 levels, sometimes I will make a port that is quite far away from the original port. The reason being, if you have 2 ports in when you do uniportal decompression, you need a higher water flow because higher water pressure, because the water will flow out from the other skin incision that you make, and hence making the difficult visualization during uniportal surgery. So in terms of visualization of instrument, the left side is uniportal surgery. You need to you are basically drilling directly in front of your lens, and hence if you want to see the tip of the instrument, you sometimes have to rotate, as you can see in the later part of the visualization. As we rotate, we can see the lamina better now. So in biportal, however, it is at the angle. Triangulation is important, and you do not need to rotate your scope frequently to visualize what you are drilling. So in terms of learning curve, both of them have a significant learning curve, and this is published in my paper as well. We usually I suggest that the beginner to do a left-sided L4-5 discectomy for biportal, and for uniportal start with just discectomy in transforaminal or interlaminar approach. Then you move on to decompression and highly micrated disc or extraforaminal approach, followed by cervical and thoracic cases, and then fusion surgery. So this video is just showing how we do uniportal decompression of 3 levels. So this is a 58-year-old hawker who basically have a back and leg pain, 3 levels stenosis, and we perform a uniportal decompression. I use 2 separate incision, one incision to do the L3-4 and L4-5, and then another incision to do the L2-3. I start at the sublaminar region. This is a uniportal. You can see that the scope, all the instruments are directly in front of your scope. There's no difficulty in triangulation. However, you need to rotate your scope frequently to do the decompression. You can see that I rotate my scope here, and I can see the lateral margin of the dura and the bleeding points. I try to do the ligamentum flavum resection as well as decompression after bony resection, because once you remove the ligamentum flavum, there's more bleeding in the epidural space. So after we decompress one level, I move out of the scope, and then I went to the next level. You can do a sliding technique now. Nowadays, I do a sliding technique, so I do not need to pull my scope out, and I can go to the next level. Anyway, this is pretty repetitive. In the interest of time, just to show that we can do the same thing for the 3 level with 2 separate incision. Basically, start with the facet, we call it V point, then move up to the cephalic lamina, then the ipsilateral caudal lamina, and then contralateral decompression, and eventually decompress both sides. And we forward a little bit faster with 2 small incision. This patient obviously in a lot of pain, previous morsifaction was done. So she went home same day. I didn't need to use a drain, and she's happy with her results. On the other hand, we have a biportal decompression on the another 69-year-old claudication with a large facet cyst. Sorry, it's a bit small in terms of the MRI. Large facet cyst here in the L3-4 and a spondylolisthesis in L4-5. I start with decompression, creating a working space, and then find the base of spinous process. As you can see here is a different view. We have start our working with the base of spinous process, dock on the spinal laminar junction, and then we can work on the base of spinous process, and using the cutting burr, we can quickly get it out. And using the osteotome, I open up the interlaminar space a bit larger, and then find the deep yellow ligamentum flavum after removal of the superficial ligamentum flavum. And we can use subsequently the cutting burr to just basically trim the base of spinous process a bit more. And then we use the coarse diamond burr to work closer to the ligamentum flavum, as we have to lean the burr on the ligamentum flavum. I suggest to use coarse diamond burr. Otherwise, you should use cutting burr with sleeve. After hemostasis, then we will be able to get to the bottom of the flavum, and then we can either use a coarse burr, as we can see here, to trim off the caudal lamina, or we can use an osteotome. Sometimes I use an osteotome as well. Depends on the size of the interlaminar space. I tend to remove the last bit of the inferior articular process with osteotome, so that I do not need to drill excessively on the IAP, inferior articular process. For the SAP, I can use osteotome as well, but in this case, I use the drill. This is the corner described by Dr. Zhang Wei just now. So I bite the corner, and then I can use the osteotome, a hockey stick osteotome at this corner to decompress the superior articular process. Or you can just complete it with use of a more curved rotatory Kerrison ronger. So this is probably what I did. I did use a more curved rotatory Kerrison ronger. Once that is done, then we remove the flavum. The flavum is loose. We remove it as one piece. I just speed up a little bit, so I separate out. So you can see the facet cyst here. We gently lift it up and decompress the facet cyst. Facet cyst can be quite adherent to the dura, so we have to be patient while doing it to prevent a dura tear. But you can see the biportal scope is like what most of the Chinese professors say is meant for stenosis. Very, very efficient system. So for the interest of time, I don't want to bore you all with another same level surgery. So I just speed up on that. So this is the decompression of the next level. And after that, the patient, again, I don't put drain, and the patient, even if 2 level, I don't put a drain, and the patient go home on the same day, happy. So basically, my personal experience in training myself and other surgeons, I find that the uniportal decompression tend to be disorienting. For I think a person to want to start the first case probably have to watch myself, whereas I train my trainees, have to watch myself doing the decompression for more than 10 times before he can even try to start the surgery. While UBE has a relatively shorter learning curve because of the ease of manipulation of instruments. but there's training required in triangulation and for UBE, and there's training required in handling of scope and instrument in uniportal. So in terms of research, both have published a lot, and we find the latest paper that uniportal have similar decompression bleeding rate as well as symptoms improvement and lower disability compared to tubular, and biportal wise have a similar operating time, complications, and ODI as well as VAS back and leg pain. These are published by a Chinese group compared to microscopic surgery. And when comparing UBE dural expansion and VAS ODI also improved compared to microscopic surgery. This is quite a landmark paper. They compare all three types of scope surgery, and they find that biportal surgery preserves the facet better than microscopic and uniportal surgery. I find that probably that's because we are quite careful in removing the inferior articular process and superior articular process. The mean operative time are similar, while the back pain score, as we are all aware now, in the early post-op period is superior in either type of scope surgery compared to microscopic surgery. Complications in many papers shows is about the same. Dural expansion, however, is shown to be better in biportal group compared to the uniportal, and it's comparable to microscopic group. So this another paper in their conclusion is pretty similar to the earlier paper. Biportal has a better lower back and lower VAS score in back and leg, and no difference in ODI in long term. And so there's no short-term difference, no long-term difference, and better dural expansion in UBE than uniportal. Well, both are better in early post-perioperative outcomes. And these are my own patients. You can see the incision has no difference in terms of the wound. They all heal very well. This post-op 14 days. I don't use a drain, so they just two small dot in biportal and one longer incision in uniportal. And you can, in terms of clinically, I've done both side or both type of surgery. A lot of them on the same day as well. They both, most of the patient can go home on the same day itself, if not the next morning. We did a study. Our mean post-operative stay is 20 hours after surgery, be it uniportal and biportal. In conclusion, I think biportal or uniportal has no clinical difference. The difference is in terms of handling and learning curve. So we have to evaluate our outcome as we do our surgery. If we are in the better group, our outcome is good, then we can do that. If not, we can consider using other techniques. So it's essentially both are good techniques to use, and it's all about whether we can, which type we prefer and our handling technique. So we have to evaluate and think about it. Thank you very much for allowing to share my experience.
Thank you, Dr. Hu. Thank you for your excellent presentation about the uniportal and the biportal. Because time limitation, we will discuss later. 下面请交给现场主持。